little hard there, but not a lot of tough pictures. You guys let me know by next Thursday whether you want to continue having the pictures on the Tuesday exam, or if you think it would be better for you to split it out and have, you know, a 20-minute picture quiz, say on Wednesday or Thursday. You tell me what you want to do with it. I will include the points in the test, so it doesn't matter whether we do it as a single or as a double, but, yes.
Would it be possible if any way, like instead of like a 30-minute like written one of it, would it be like in the scopes if we had all of them set up? Or would that be?
No, because I have to have you all looking at exactly the same cell.
Ah.
Yeah, and that ain't gonna happen, not in the microscope. You will be tested in the microscope because I have slides that have ranges, okay? But there will be specific, what is this cell, what is this cell? When you get to the boards, they don't do it that way. What they'll do is they'll give you kind of a case history scenario kind of thing with the picture of the cell. So trying to put all the pieces together to make this work, but if you think it would work better for you guys to split that picture section out, I honestly don't care, and I honestly don't care if each group does it differently. I'm flexible, but there's usually 10 pictures. Spelling, I'll give you a couple of letter error, but it's gotta be relatively close. Okay, I had somebody who put a myelin site instead of a myelocyte. Okay, I'll take it. But try and make it close. Don't make me get too particular. It's what?
5 pages each, I'm just telling you.
And she has 20 blue M&Ms. What percentage of blue or of M&Ms are blue? Alright. Trisha's gonna get 100 of them. She's gonna get 20 blue. Relative, absolute. Okay, so her relative is 20% and her absolute is 20, right? Nicole, you're gonna get 1,000 M&Ms. But my son got to the package first, so you are only going to get 2 blue M&Ms. Okay? So what is the relative number of blue M&Ms? 0.2%. I take my total number, I divide how many blue ones I have by my total number. That gives me 0.2%. But what's her absolute number of M&Ms? How many, oh, I did it backwards, didn't I? Okay, so she's got 0.2. What's her absolute number? It's 2. We'll get somebody else. Tiana, I'm going to give you 200 M&Ms. Okay? You're going to get 1% blue M&Ms. How many blue M&Ms does she have? How many blue M&Ms does Tiana have? This is just math.
2.
With the decimal point, how many spots? So Tiana has the same number as Nicole, right? Patricia has a relatively increased blue M&M population because 20% of her M&Ms are blue. She also has an absolute elevation in blue M&Ms, right? Let's go the other way. Chris, I'm also going to give you 100, but you're not getting any blue M&Ms. Sorry, David got to the bag first. Okay. So your relative is 0. Your absolute is 0. Your relative and absolute counts are less than anybody else's, right? I am going to give, Leah, I am going to give you, you're only getting 5 M&Ms, but they are all blue.
5%.
So we've got, she's got 100% blue M&Ms. But she's only got 5 blue M&Ms. So her relative percent is higher than everybody else's. Her absolute number is higher than everyone but Patricia's. Does that make sense? I still see blank. I hate trying to teach this. I need piles of them. I'm gonna make a video with piles of them and those. Does anyone understand it well enough to help me out? Help me explain it to the rest of the class. How do I tell the difference between an absolute and a relative difference?
Relative is more with percentage and absolute is more with the ratio.
Well,
Like you have a 5 to 5, that means you're everything. If you have a 2 to 10, that means you have a 1 to 5. So you have more of a given standard or something?
the absolute's more about how many are in the pot. The relative is more about how much of what is in the pot is blue. Alright, does that,
Absolute is an exact number.
what?
Absolute is an exact
The
number.
absolute is an exact number, I can count that. Okay. The relative is the ratio, the word you used, ratio. That's exactly, the relative is the change in ratio. Can anyone think of another example other than M&Ms that might work better? I have so much trouble with this. It's a very simple concept, but until you get it, the rest of this stuff doesn't make sense. Okay. The absolute number is, if I put them on the counter and had somebody count them, they could go 1, 2, 3, 4, 5. But the relative is the ratio, what percentage of them. And I think we talked yesterday that diffs are really not about numbers. They're about ratios. Okay. So I can have 100% lymphocytes, but if I've only got a 1 white count, I don't have a whole lot of lymphocytes, do I? Or I can have, 1% lymphocytes, bless you, and I can have a 100 white count, and I definitely have more lymphocytes than if I have a 1 white count, right? Yes.
So is the M&M, those are like the CBC and the blue M&Ms would be the WBC?
This would be your white count.
Okay,
This would be your differential count.
okay.
Okay? Yeah, that's usually how I end this is if I just replace this with WBC and this with diff. It's all the same. And okay? So the point is you have to not only look at what is the absolute counts, but what are the relative counts also? And those relative counts, how many neutrophils do you have compared to the total number of cells you have? How many lymphocytes do you have compared to the total number of cells that you have? Okay. This is just definition. You should know all of this from medical terminology. Pretty much in hematology, you're either going to have an anemia, an osis, or an apathy. An anemia is a decrease, an osis is an increase, aphilia, I don't know why they decided philia for that one. Aphilia is an increase, and an osis is an abnormal. Okay? So if I have, an apathy is an abnormal. So if I have leukopenia, I have a decreased white count. If I have leukocytosis, I have an increased white count. we look at the cell types, I have neutropenia, my neutrophils are decreased. What do you think is decreased in lymphopenia? Yeah, don't make it harder than it is. Tear the words down. And why they decided neutrophilia, I think it was just to frustrate me on it. Hundreds of years ago, they knew I would be teaching hematology and they just wanted to see me frustrated. A shift to the left, a left shift, this is a very common term you'll find. A left shift means that I'm starting to report out more immature granulocytes. So what was we only talked about one of those so far. Which cell did we talk about as an immature granulocyte? Yesterday.
What was that again?
We talked about a cell yesterday that is an immature granulocyte. What cell was it?
It's either monocytes or lymphocytes.
Mm-mm.
Should
Had to be a white cell. We'll narrow it down to that. Which one was a slightly immature neutrophil?
Is the ET for the band or the
The band. The band.
Okay.
Band is a slightly immature neutrophil. Okay? So what we're going to see in a left shift, yes?
I thought the band was the one that it looked like a band across the cell, the one that had looked like a pimple or something like that. That's what I associate with it.
No, the band is the one where the nucleus, here's your cell.
It looked like an actual rubber band, like torn.
A band is this. This is purple.
What was the
Was
one
the
that
book
still
called that
has?
single lobe? Or the?
Yeah,
Atlas, I
it's
think?
not lobulated yet, so I guess calling it single lobe would be appropriate.
Okay.
What was the one that had just a little bit of the nucleus left over, like if it wasn't completely mature? Or get rid of the nucleus?
That was one of the red cells. We're talking white cells.
Okay.
We're talking white cells. Be on examination of peripheral smear. And you might want to know that for now? Or for Tuesday, sorry. A band is a slightly immature. Yes.
Is that the same as the horseshoe one?
No, the horseshoe one
Or is that the normal?
the monocyte. And the way you tell the difference is because that one's going to have blue cytoplasm, not granulated cytoplasm. Okay? I promise this will all make sense. I really, really wish I could put a camera here and film y'all the first couple days of class. And then when you come back for review week, just pull up snippets. Y'all would laugh yourselves silly. Because you're all sitting here now going, and when you come back, you say, so I've seen these exact looks before, okay? And every one of those people has passed their boards, so don't freak out yet. Troubleshooting is the ON-OFF switch in the ON position. Okay. Granulocyte kinetics simply means where are my granulocytes at? They roam around in my body. They form in the bone marrow, and we'll go into that a lot later. But changes in proportions of the marginating pools to the circulating pools. You got places they kind of hang out. Your white cells are your army, okay? Some of them are stationed on the front lines, circulating through the body, attacking whatever's coming in. Others of them, they're back at the reserve base, so that if you have a really massive attack, you can mobilize them to where they need to go. That is your marginating pool, okay? And those are found in the spleen, bone marrow, several other areas throughout your body. So anytime we have to shift our reserves and get those out into the actual circulating pool, out into the active area, we have to quickly then recruit more people and get them into the circulating pool so we always have backup. Well, that takes a little while. You can't just do that, boom, boom, boom. It takes some time to do that. So what a lot of times what the left shift is all your reserves have been called out, and so you've got some really green soldiers that you're putting into your reserves. You've got very immature ones, okay? And in some cases, those new recruits, so to speak, they have to go to the front lines too. So when we start seeing the youngins out in the circulating blood, be they white cells or red cells, that's never a good thing. A left shift just means we have an increased number of bands. It just means something is going on that has put a stress on your system, okay? You can see a left shift that is gone 5 minutes later. They've done studies where they've drawn little kids. How many of you have drawn children? None of you have had to draw kids? You have, okay. Or have kids who've been drawn. They sit there and they scream and they yell and they holler. Ah! If you draw a CBC, if you can get one before they start to scream and holler, and then draw another one at the end, there actually can be as much as a $5,000 to $10,000, or $10,000. Oh, Diane, you need to wake up better. A $5,000 to $10,000 difference in the white count between the time you start and the time you finish, just because they're sitting there screaming and hollering. Labor patients, the same way. They're laying there, no contraction, no problem. If you drew a CBC right then, and then they had a labor pain, and you drew one while they're having a labor pain, you honestly can see a 3,000 to 5,000 jump in their white count, just because of the stress of that imminent situation. Yeah.
What in stress is being released to activate?
The neutrophils, you're having an inflammatory reaction, the neutrophils are coming out to help.
Got it.
Okay, and that they're sitting in the marginating pools, so it only takes seconds for them to get into the circulation, and it only takes a minute or two for them to circulate through the body. So you literally can see a patient, if you draw them and they're not stressed. I mean, I guess if we were really cruel and inhuman, we could draw somebody who's nice and relaxed and then hit them with a cattle prod and see what happens at the end of the, you know. I think we'll skip that. But you understand what I'm saying is that you can have a change in your white count within minutes. And then if you were to get that little kid calmed down and draw them again without the trauma, their white count will have gone right back down. So we do see this occasionally. Okay. Alterations in leukocyte number and maturity. Neutrophilia is defined as an absolute count greater than 8. And I have to check the book because I know that changed. I mean, make sure I changed that. But it's greater than 8.0, absolute. So how would I get that number? I'm going to take my white count and I'm going to multiply it by the percentage of neutrophils. That's going to give me my absolute neutrophil count. Okay? Or, as it is often called, I really wish I could figure out how you can write directly on that board. You're supposed to be able to. It doesn't work. My ANC. First time somebody called and asked me for the ANC, I'm like, we figured it out. We have pharmacies call us for this quite often because in certain cancers, certain leukemias, they base the medication that they give the patient based on what their ANC is. So in other words, the patient will come in, have their blood drawn, then they'll go to the pharmacy, we'll fax the report to the pharmacy, and the pharmacist will take the ANC, and the doctor's prescription will read something like, you know, give 0.4 milligrams per unit of ANC. Okay? So it's based on, if your ANC, if you're trying to get rid of neutrophils that are leukemic, they're going to give you more. If you're trying to get rid of the lymphocytes, as your ANC rises, they're going to give you less. Okay, so they actually have several chemo drugs out there now, several anti-leukemics, that they give based on the ANC. And I believe there's even a dialysis drug that they give based on the ANC. Don't quote me on that one because I don't know for sure. Yeah.
You said ANC stands for what?
Absolute neutrophil count. Absolute neutrophil count. And when we're calculating this up, we have to add in the bands. Okay, so if I've got 60% bands and 10% segs, I don't just take that 10% segs and multiply it by the white count. I've got to add the bands and the segs together and then multiply by the white count. to get that absolute number. Leukomoid reaction is just a fancy way of saying you got lots of neutrophils. Okay. We see a shift to the left, a leukoerythroblastic picture. We see increased nucleated red blood cells, and we'll talk a lot more about that. I won't ask you anything on this test about leukoerythroblastic picture, because until we talk about the erythrocytes, it don't make sense. Okay? Leukopenia is any absolute white count. In other words, if you did the white count and it's less than 2.3, then that is going to be leukopenia. But to tell if it's neutropenia or lymphopenia, you have to calculate the absolute counts. Okay. I can have a rise in my neutrophil percentage because I have a fall in my lymphocytes, right? Or I can have a fall in my lymphocyte percentage because I have a rise in my neutrophils. So to be able to tell which cell line is screwed up, I need to look at the absolute counts. Okay, that's it for that. Okay. I can tell you right now that there are going to be case studies on this test. And I'm going to put pieces together. So that we just talked about is going to be one of those pieces that's going to fit into the case studies. Hyposegmentation, alterations in neutrophil morphology. Neutrophils look funny for some reason. Hyposegmentation just means that there's only 2 lobes or less, and they're supposed to have 3 to 5. Okay. It's called Pelger-Hewitt, probably named after the people who found it. The nuclei are round, maybe slightly oval, bilobed with a pinched appearance. You know those old-timey granny glasses that are 2 little circles with the little wire that goes over the nose? Or those way before your time. But they call them pince-nez. It looks like, this is what they look like. They look like the 7-Up dude. Okay? That's better than old glasses. Okay, we'll go to the 7-Up dude. Okay. But this is what all of them look like. There's absolutely nothing wrong with them. This is a seg. This is a seg in a person with Pelger-Hewitt. If you have someone who has something called the Sturtevant variant, they all look like that. You want to talk about a confusing diphthery. The only way you'd catch it is by knowing that's what he has. Okay. The clumping of the chromatin, and what is the chromatin?
DNA.
Pardon?
Isn't that like where the DNA is?
The DNA, okay. Morphologically, what does it look like? The purple stuff, okay? And when it's dense, it looks more like a lymphocyte nucleus than it does, the chromatin pattern looks more like a lymphocyte chromatin pattern than like a neutrophil pattern. It tends to be a little more dense on these guys, okay? It's cute, but quite frankly, it's totally clinically insignificant. It's just, like somebody who has a pinky that's, always bent over. Or somebody who, for some reason, their wrist wiggles wrong. It's just a morphological characteristic. It has no significance to anything. Pelgeroid cells, or pseudo-Pelger-Hewitt, looks exactly the same. Basically, it's acquired, and it's usually acquired because of certain medications that are given. Do I know which ones? No. Do I care? No. Once they stop giving the medication, it goes away. This is inherited. It's totally benign. We don't see it very often. It's just not one of the characteristics in this area. We see this one once in a while. Sometimes drug reactions is our biggest reason for it. Patients with severe burns or really, really severe infections will sometimes also develop this condition, pseudo-Pelger-Hewitt. It is not significant in and of itself. You have to look back and see what's causing it. If they have leukemia, well then I guess technically it's significant. Okay. But not because it's Pelger-Hewitt, simply because leukemia. Alterations in neutrophil morphology. This one's much more common. Hypersegmentation means it has more than 5 lobes. This is the most hypersegmented cell I ever found. That's got lots. Normally you see them, they have 6. And not just one of the neutrophils has 6, but a good number of them, that you see several of them that are hypersegmented. Hereditary hypersegmentation, just like anything else, there's some people whose their stuff just looks weird. Okay? It must be distinguished from true hypersegmentation, and we're going to do that by doing some more lab tests. Okay? Where it really is important is in megaloblastic anemias, okay, which is our B12 and folate deficiencies, which we will talk about ad nauseum in a few weeks. But basically, oval macrocytes and hypersegmented neutrophils equals megaloblastic anemia. It is one of the few things you can actually, I mean, we have a few disease states. You put the slide on the scope and go, oh, look, this guy has megaloblastic anemia, because it is very morphologically distinct. Patients with hypersegmented neutrophils need to have a B12 folate done just to make sure that everything's okay. You can see twinning, which means basically it's a mirror, the nucleus is a mirror image of itself. We talk about it. I've never seen it, and I really don't care, but they talk about it, so it's part of my stuff I gotta teach, so there, I taught it. If you see an increase in what they call drumsticks, it looks like a chicken leg hanging off the edge of a seg somewhere, or extrusions or little pokey things coming off of the nucleus. Again, we see those sometimes, mostly in chromosomal abnormalities, so we see them mostly in children, although it can be in patients who have leukemia. Don't spend a lot of time. Alder-Riley, and yes, you do have to know which of these great big funky words goes with each of these characteristics, okay? So it's a deposit of mucopolysaccharides, or increase in lipids in the cytoplasm of the neutrophils. We're still talking about neutrophils. So what you get these cells. These aren't basophils, because these aren't those big blue-black granules. They're fine and they're distributed more evenly throughout all of the cells. And it's not particularly significant, other than you have to differentiate it from toxic gran or a clinically significant. Shidaya Kigashi, remember we talked about horses and zebras? This is a zebra. This is an albino zebra. Okay. There's only a small population in the world who actually suffers from this. And you can butcher that name any way you want. Shidaya Kigashi, Chidiac Higashi, I've heard Chedjiki, however you want to say that, I don't care. But Shidaya Kigashi, there's a risk of infection, and the thing that goes with this, and as you're going through the program, my class and everybody else's class, if you can find little keys, little hints that will help you match up a disease state, Shidaya Kigashi and albinism. What is albinism?
White. They're like, yeah.
What'd you say?
White, like,
white,
yeah.
White, beyond white, like colorless, as in their eyes actually will sometimes be red because they don't even have any coloring in their iris, so you can see straight back to the retina. So yeah, white beyond. Their hair is pure white, like polar bear white. Okay, so absolutely no color in their skin, and it is found in Asians, so it's can be a little bit disconcerting. Okay, so they have large peroxidase positive. They're peroxidase granules, or peroxidase lysosomes. They're either blue-green or big purple, and that's about the only pictures I found on the internet. I've never seen it, and like I said, those are about the only ones that I really could even find, and they're not very good. And when you start Googling for some of these pictures, some of the stuff you get, I don't know how the search engine works on some of it. May-Heglen, you talked about that. Its clinical significance is really not hematologic so much as it is coag. So you guys talked about May-Heglen and coag, yes? Okay. The thing with May-Heglen that hits us in hematology is that you have these great big blue splotches in there, okay? And they can be mistaken for Dolly bodies, which we'll talk about in just a minute. Okay? They can be mistaken for Dolly bodies, so you need to be sure, and Dolly bodies indicate infection, so you have to be careful that you don't confuse that. Leukocyte reaction, that's the one I told you if you're drawing a screaming kid, this is what causes their white count to go up. A leukocyte reaction is any time that you release a large number of white cells into the circulation, okay? There's an increase in white cells, generally with neutrophilia. Your relative neutrophil count is going to go up over 90. Your absolute neutrophil count will be over 8, okay? We often see a left shift associated with this. Toxic granulation, vacuolization, and Dolly bodies, and possibly even an increase in necrobiosis. And you're going, what are those? Hang on there on the next slides. Okay. Toxic granulation, in a slide stainer, everybody's neutrophils look about the same from slide to slide. If you start seeing one patient who has a lot of granules, they're going to be darker, they're going to be more prominent. What they are is altered primary granules that have been activated by the presence of foreign bodies. Okay? They tend to be darker, blue or black in color instead of the regular pink or light blue. The greater the proportion of affected segs, the graver the prognosis. How do I tell the difference between toxic gran and Alder-Riley? Anyone want to make a stab? Because Alder-Riley had those big purple granules.
The band on the inside?
The band? Well, Alder-Riley sometimes you can't see. So that would be, yes, that you have a left shift, you have bands.
So what about the little,
The proportion of cells. How many of the cells in Alder-Riley are going to have this granulation? Want to take a guess? All of them. In toxic gran, it's not going to be in all of the cells. It also is often not spread throughout the cell. You'll actually see it, it'll kind of cluster off to one side. Okay? They cluster within the cell, and not all segs are affected. So if every seg has this granulation, that could just be the way that person stains in the slide stainer. Dolly bodies, these are found in the cytoplasm of segs and bands. Okay, bless you. It's a little bit of RNA arranged in parallel rows. They tend to be kind of cigar shaped, even though these are fairly round. And I have a new slide that I just got 2 days ago, and I can take pictures. The problem with Dolly bodies, I don't have a slide I can put under the scope for you because they don't hold up. So unless I have a really fresh slide, you're not going to see them under the scope. They disappear. They fade out within just a couple of months, and I can't find them again. They just deteriorate. Even after we fixed them, stained them, and everything else, they just deteriorate. They're transient. You'll see them for a day or two, and then they go away. They're non-specific, even if we see them in pregnancy. The biggest thing that we're going to look for is that they are significant in the overall clinical picture. So if I'm doing a diff and I'm counting a lot of bands, I'm going to make a special note to slow down, maybe even go down to a higher power, and look more closely for toxic gran and Dolly bodies, because toxic gran and Dolly bodies mean I have something acute going on. Simple neutrophilia can be chronic or it can just be transient, can be just stress related. But if I've got an infection or burns or some sort of major something going on, then I will see the toxic granule in the Doble bodies also, okay? The EDTA exposure, if it's been sitting for a couple of days, these Doble bodies will be more gray than they will be blue. Again, I don't know that that's particular. Vacuolization is holes. You should not have holy cells, except which cell normally has holes in it. Yesterday I told you there's one that normally sometimes has holes, has vacuoles. Which are your 5 major white cells, has vacuoles. Hint, it eats things.
You say
Macrophage.
The macrophage. What do we call it when it's in peripheral blood? No, mast cell is a basophil. It's in the tissue. What do we call a macrophage?
Monocyte?
Well, phagocytosis is what it eats.
Monocyte?
Monocyte. Okay, it's a monocyte when it's in the peripheral, it's a macrophage once it starts having lunch. Okay. Autophagocytosis, sometimes certain medications will cause the neutrophils. Basically, these granules have a peroxide, sort of like hydrogen peroxide, and when they go and eat something, they go over and they engulf it with their pseudopod, that's biology. Then they break these granules open and kill the bacteria. Unfortunately, it's a suicide mission because it also starts to kill the white cell. Well, sometimes that starts to run amok and they start eating themselves instead of just bacteria.
Is that an immune disorder?
What was that?
Is that an immune disorder?
It can be a lot of things. It can be just because it got stored too long and there was nothing left to eat. It can be certain medications will cause it to do that. It just can be time that the granules break down. Ingestion vacuoles, that's where they've eaten some sort of bacteria or whatever. And I even have a couple of slides and a couple of pictures where you'll find bacteria inside of the white cells. Necrobiosis, it just means it's dead. Okay, and if you look, can you see the difference between the chromatin pattern here and the chromatin pattern here? Okay, this still has some white areas in it. It's got some clumpies in it. This is nothing but just solid. Smooth, absolutely no variation to the purple coloring. If you see one of these, oh, look at this. That's nice, get your diff done. Okay, if you see a bunch of these, you probably need to report them. We don't count them in the differential, we simply report them off to the side. Increased necrobiotic cells present. And I would say you need to have 3 to 5% of your diff look like it's these guys before I even say anything. You're going to catch a weird one once in a while. This does not fit anywhere. This just simply does not go anywhere else, so I slapped it on the end of this one because I got to talk about it, but it just doesn't really fit anywhere. Chronic granulomatous disease is a non-morphologic. What does that mean?
Doesn't look like anything.
Doesn't look like anything. Everything looks normal. However, remember those lysozymes I told you about that break the bacteria down? They don't work. So there's a defective intracellular kill mechanism. So they go over there and they engulf the bacteria and then they can't do anything with them. They've basically just invited them inside and they can't kill them. About a 6-to-1 ratio, boys to girls. It is predominantly male, although it is not it is not sex-linked. There's an increased risk and susceptibility to infection. Generally, these children die before they're about 7 years old. Modern medicine has extended. Some of them make it into their early teens, but it's very rare. It doesn't come up very often, except on board exams. Yes.
Why is mortality rate so high?
Because they can't fight off infection. Even with antibiotics and stuff, you have to have your body's immune system to fight off just the day-to-day exposure to bacteria, viruses, fungi, abnormal cells, and everything else.
Maybe I heard you then, because I thought you said that the white blood cell will do the phagocytation and suck it in there, so that would stop it from reproducing.
No, because then it just eats the white cell and reproduces. There's plenty of protein, minerals, warmth, water,
So it's not a
everything.
containment, it's just
Yeah,
the food source at that point.
pretty much, yeah. There's very few of these cytoplasmic alterations of monocytes or macrophages. The first one is called Gaucher's disease, and this is a lipid storage disorder. Yes, you do need to know that glucocerebroside is missing in Gaucher's disease. We see Gaucher cells in the bone marrow. You will not find these on your peripheral blood smear. They are in the bone marrow. Okay. It's a large cell with an eccentric nucleus. It has been described as chicken scratch cytoplasm and as crumpled tissue paper. And I know somebody who actually got one of these on the boards, and in the description it said chicken scratch cytoplasm. Okay, so they actually used that terminology on the board exam when they talked about the Gaucher cell. Now what they were asking was for glucocerebroside. The student didn't remember that part of it. They remembered Gauchers and chicken scratch, so they could rule out a couple of the answers that they knew were wrong, right? So anything you have to help. Niemann-Pick, this is a deficiency of sphingomyelinase, and there are, no, we only talk about one of the other ones that's a deficiency of sphingomyelinase. Niemann-Pick cell, we find this again in the bone marrow. It's a large cell with an eccentric nucleus or nuclei and a foamy cytoplasm. It looks like dish foam. You're Mr. Bubble. Lymphocytes. Lymphocytes are pleomorphic. Pleomorphic means they can look like anything you want to. Generally, your basic lymphocyte that's just floating around in your bloodstream, not bothering anybody, going about its merry way, doesn't look like anything. It's little nucleus, scant cytoplasm, all happy hunky-dory. But when it finds something that shouldn't be there, it's like a cat. Its fur expands, it grows in size and turns into this ugly looking thing, okay? So it gets big. We have reacted or stimulated or variant lymphocytes. They go by a bunch of names. Most commonly they're called ATLs, for atypical lymphocyte. Okay? A lot of places call them ATLs. They will have a larger nucleus, and as the nucleus expands, the cytoplasm will get, as the nucleus expands, the chromatin, the chromatin will become more loose. Okay? You're going to start seeing an increase in cytoplasm. You're going to get more and more cytoplasm on these cells. We're going to see abnormal chromatin clumping patterns, increase in cytoplasmic basophilia. Fancy way of saying it's going to get darker blue. Okay? They can be heterogeneous, so all of the lymphs can be different. You can look at in one slide in one field and get 10 different types of lymphocytes that you see. Okay? You can see fragile or indented cells. Nuclear abnormalities of the lymphocytes. I'm not going to push too much on this right now. For now, what you need to remember is that nuclear abnormalities tend to be associated with malignancy. So if the cytoplasm's just funky and weird, it's probably just some sort of virus or something. Okay? But if you start seeing differentiation or changes in the nucleus, we may be dealing with a lymphoma or other type of malignant dysplasia. We got a whole PowerPoint on those later. Cytoplasmic abnormalities, we can see vacuolization. Like I told you, the difference between a monocyte and a lymph is the hardest thing I have to teach. And there are going to be times Melissa and I are just going to come over and go, is it a lymph or a mono? It's a lymph. Well, why? Because I said so. okay? After you've done them long enough, sometimes you just kind of, you just learn. When we talk about doing differentials, and I talk about trying to tell about the difference between lymphocytes and monocytes, try to explain to someone who's never seen a cat or a dog, based on a 2D picture, what characteristics that can you give me that will differentiate a cat from a dog? 2D picture, face only. How can I teach somebody to tell the difference between a cat and a dog? Seriously, give me some.
Well,
What
dogs
could I do?
don't have cat eyes.
The eyes are a little different,
Yeah.
but not all cats have the same kind of eyes, do they?
Yeah, but they have the same pupils.
Oh, hey, that one I hadn't heard before. You're right. We actually have one. Okay. Whiskers? Do dogs and cats both have whiskers? So seriously, kitties and puppies. How do you tell the difference between kitties and puppies? And since you gave me the eyes, and you're right, I'm gonna make their eyes close now.
One will jump from like a 15-foot tall bookshelf, one wall.
We have a 2D picture of the face, not a functional area.
Oh.
Their whiskers,
Size of the nose?
their whiskers stick out.
Some cats have big noses, some have little ones.
Cats
Some dogs
a-
have no nose.
Cats have like a fist face, it's like kind of small, while dogs are more like elongated snout kind of.
Not always.
No. But more times
Okay,
than not.
more times
Hugging a
than,
cat or more.
thank you, more times than not. More times than not. Oh, I'm stealing that one so bad. More time, yes, you're right. Some things you can just look at, but if I put pictures of kitties and puppies up here, that's a kitty, that's a puppy, that's a kitty, that's a puppy, without me being able to say so, tell me why, you'd be able to look at it and you just know, right? Why? Because you've seen so many pictures of kitties and puppies. How do I know the difference between a lymphocyte and a monocyte? Because I've seen so many lymphocytes and monocytes. After time, you learn. Yes?
I'm a little confused. Are we doing diffs on a regular blood draw or from the bone marrow?
No, blood draws. I have one bone marrow slide you all will review. The only reason I show you the bone marrows, the ones that are in the bone marrow, is those slides. Those are particular cells associated with particular diseases, and those do come up periodically. It's the best place to put them.
You would do other tests before you'd ever get to that point, I guess, of seeing them in the bone marrow? Okay.
Yeah, we'll talk about, you'd see the symptoms first, and then go from there. And we'll talk about bone marrows later. Epstein-Barr, what do we commonly call Epstein-Barr viral disease? Mono. Mono. EBV is the cause of mono. We find it most commonly in children and young adults. Clinical presentation, severe TBS, tired butt syndrome. That is not an actual clinical term, guys. Malaise, which just means laying around. You know, in teenagers, sometimes it's hard to tell the difference. Fever, chills can be present, sore throat, cervical lymphadenopathy, which is why I did a mono test on myself last night. I don't have it. Occasionally we'll see splenomegaly. In the CBC, what we're going to see is we're going to see an increase in reactant lymphs. Okay, so most of the time if I see variant lymphs or ATLs, reactive lymphs, it's going to be associated with viral disease. Functional alterations, that's nice. I ain't gonna spend a lot of time on this. Agamma-globulinemia just means you don't make immunoglobulins. You don't make antibodies. Okay. The Wiskott-Aldrich, it's a defect in both B and T cells. That's about all you need to know about those. Okay. Obviously, I'm not gonna spend a lot of time. I have to make sure I include all this stuff, but some of it's more important than others. Variant or reactant lymphs, the old way of classifying these old downy lymphocytes, type 1 are the plasmacytoid lymphs, and we don't call them type 1 anymore. If we report them, we actually report them as plasmacytoid lymphs. We don't call plasma cells in the peripheral blood. We call them plasmacytoid. Saves us from lawsuits. Okay. The infectious monocells, these are scalloped or irregular. They call them like a fried egg or a skirt. This is the one we talked about where they wrap around the red cells and they get dark blue where they do. Type 3, everything else that isn't type 1 or type 2. I will send out this afternoon a review sheet. It's going to tell you exactly which PowerPoints are on there. I will also include which lab tests are on there. Okay? And keep in mind for the lab tests, you need to know how we do it, calculations, reagents, sources of error. Okay, those are all things that are fair game for the test. In fact, I'll find the objective that tells you exactly what, and I'll paste that in this particular one. I will also give you a list of cells that are eligible for the picture review. Okay, and the picture review is just that. I put up a PowerPoint slide that has 10 pictures. You have a piece of paper with 10 lines. You will tell me what type of cell it is. This one, we don't have a whole lot of cells we've gone over, so it's going to be pretty straightforward. Make sure you know by next Thursday whether you want to keep the pictures in the test on Tuesday or whether you want to schedule a separate time to do them. Okay? And I don't care either way. It makes me no, never mind. Depends on when I pull up the thing. Yes.
2 questions. So are we gonna need a calculator?
Yes, you are going to need a calculator for the
Okay.
test.
And then for the cell pictures, is it like the type of cell, or is it you're gonna give us like a cell and we have to name the disease?
It is for this first one. It's just going to be what is this? What is this? As we go along, it will start having arrows. What is this inclusion? Or, you know, what is this? And then by the end of the semester, it will be. This is what you saw on the slide. What disease state do you think it is? Believe me, when I put up disease states, they're pretty much, you know, smack you in the face. Even the techs who've been doing this for years, I can put it up and go, what's this? And they can answer it. And you'd be amazed what questions they can't answer. Because I was doing something the other night. How do you know this? I teach it. Oh, that's right. Nobody remembers that. So you will get done with school and immediately empty your brain. Okay, so lab time, go ahead and take 15-20 minutes if you want it. Like I said, I'm not